but I slightly altered the perspective because this is supposed to give an idea about all you want to know about coloboma. I didn't concentrate much on the management part, unfortunately. So I thought I will probably introduce you to the subject, and the last 1 or 2 slides just will talk broadly about management, but not in detail because we had that subject covered yesterday in another course. But these are basically some of the studies we have done on coloboma of the choroid, mostly observational studies. We all know about the embryonal fissure and its importance in the development of the eye. We know that it forms at about 7.5 millimeter stage of the fetal development and closes by 10 millimeter stage or about 6 weeks. It's totally closed except the most proximal portion. And the embryonal fissure is required to allow entry of mesenchyme into the eye that leads to the vascularization, and also it allows exit of the nerve fibers outside the eye. These are the two purposes served by the embryonal fissure. Okay? Although it is supposed to occur mainly infero-nasally, rarely, technically speaking, embryonal fissure can occur anywhere within the thesis degrees of the eyeball. So rarely you can actually find a coloboma superiorly. In fact, I had one such case, except that I couldn't prove or disprove it because when you took a fundus photograph, they think it's an inverted photograph, but it's not actually inverted photograph, it's a coloboma at 12 o'clock. Okay? Now, improper closure of the embryonal fissure is the cause for the coloboma, and mostly it is due to teratogenic insults in utero, and in the developing countries, it's much more commonly seen because we have a lot more teratogenic insults taking place than the Western world. So if you present the number of series of your cases, they'll be astonished at how you can see so many cases when we hardly saw even one case in my entire ophthalmic career. It's just because you don't see it because it doesn't occur that often in the developed world. In the developing world, we see it pretty commonly. So a typical coloboma is seen located inferiorly or infero-nasally, tends to be bilateral, but the involvement can be asymmetrical, and it's associated often with overall global insult as well. That is, the eyeball tends to be smaller in size, although there is a coloboma which is restricted to the embryonal fissure area. So there is an effect on the global development of the eyeball. And nystagmus can be present depending upon how much the macula is affected in both eyes. The variables in the morphology would involve the optic disc, the macular involvement, anterior-posterior extent of the coloboma, transverse extent, and the extent of the ectasia of the thinned out sclera. Now, histopathologically, I would refer you again to the excellent contribution by Dr. Schubert from New York. In this article, he has shown histopathologically that the retina near the coloboma margin actually splits into 2 layers. And what you see here, for example, the inner layer continues as the intracalary membrane, and the outer layer turns back and merges with the retinal pigment epithelium. So this is where there's something like a reduplication of the photoreceptors sometimes can be seen on a histopathology. And it is this junction which we call as a locus minoris resistentiae, which is an important point where communication between subretinal space and subintracalary membrane space can be established, leading to clinical detachment of retina beyond the colobomatous margin. So in our first of the series of publications on coloboma, not really, this is about the second publication of optic disc in coloboma, we described 6 varieties of disc involvement in the coloboma. The first 3 are where the disc is located outside the visible choroidal coloboma, and 4, 5 and 6 are where the disc is within the coloboma. In type 1, the disc is normal looking, I wouldn't say exactly normal, but nearly normal looking, and is outside the colobomatous margin. In type 2, the disc is obviously abnormal. I called it as a dysplastic disc, although one reviewer had an objection for the term used dysplasia, but I stuck to it. And this is still outside the coloboma, although you do see some chorioretinal atrophy in the area which is beyond the colobomatous margin. More about that a little later. In type 3, you have a coloboma in the optic disc, but the coloboma of the choroid is outside the disc itself. And this particular kind of a coloboma can be eccentric or concentric. This is the eccentric variety where you see the superior part of the disc nearly normal, but inferior part of the disc is abnormal. It's got a scalloped appearance. While if you see this one, this almost mimics a glaucomatous cupping. But here also you can make out the coloboma here, and this patient doesn't have glaucoma actually. So this is the type 3 variety, A and B. And type 4 is where the disc looks nearly normal, except the upper part has got somehow submerged in the ledge formed by the coloboma. But this is the normal looking disc with normal emanating blood vessels from the lower pole of the disc. This is type 4, where the disc looks normal, but there is a coloboma involved in the disc area. Type 5 is the most common variety, where we see a disc coloboma along with a choroidal coloboma, and the whole thing is a single area of coloboma. You do still see a functional disc which is yellowish or creamish in color compared to the lower part of the disc which has got totally scalloped in by the colobomatous process. And type 6 is where you hardly see any disc substance, you just see vessels emanating along the margin of a large coloboma. That is very difficult to even photograph because they have very poor vision, very often very severe microphthalmos, so we couldn't even capture it by photography. Then we describe the patterns of breaks in the intercalary membrane. This is actually a wrong term. These are not retinal breaks because there is most often it's the intercalary membrane, which is fibrotic tissue, maybe having some retinal layers in the immediate vicinity of the colobomatous margin, but once you are beyond the point, it's just fibrotic tissue. So it's actually a pattern of breaks in the intercalary membrane I was describing, not retinal breaks. So this is one variety of breaks we have seen. Ignore the peripheral breaks, which are like any other retinal break, but within the coloboma, you see this is a fundus drawing and a corresponding magnified photograph of the same eye. You see this border of this large oval break within the intercalary membrane. And this can lead to intercalary membrane detachment, and subsequent retinal detachment would depend upon whether there is a break also at the locus minoris resistentiae. And you can see in this case that the intercalary membrane is detached up to the point where this break is located in the intercalary membrane. The location of the break could be difficult to detect depending upon the amount of RPE atrophy and how diligently you are looking for these breaks. The second variety, in fact this is the most common variety of breaks I have seen in my series, are breaks right at the margin of the coloboma, where one edge of the break, this is the edge of the break, is lifted up with the intercalary membrane, which is lifted up, while the second edge actually is merging with the colobomatous floor. So this is the kind of break in the intercalary membrane that are most commonly found. And as you can see, this clinical detachment of retina is extending into the intercalary membrane. There is no peripheral break. It is this break in the intercalary membrane coupled with the break in the locus minoris resistentiae that is responsible for the clinical detachment of the retina. The next variety of ICM breaks were multiple breaks that you see. You can see in this case there are 3 breaks. One here, second one here, and the third one here. Multiple breaks in the intercalary membrane as shown in this drawing. Again, this contributes to ICM detachment and on to the clinical detachment of retina. And the fourth variety is involved in the macula, which itself is involved in the colobomatous process. This is the macular hole caused in the intercalary membrane. This macula is non-functional. However, you can see still some vascular pattern around the macula intact superiorly. Then we published our studies on OCT in the colobomatous margin. This threw up some interesting data and hypotheses. One is there are pigmentary changes along this colobomatous margin. It's not really OCT, but basically an observation along with the fundus photography I have done along with OCT. That I do see sometimes a lot of chorioretinal atrophic changes and pigmentation beyond the visible colobomatous margin. Now what is this caused by? My hypothesis is it is caused by subclinical detachment of retina caused by traction of the intercalary membrane at the colobomatous margin. And very often you may or may not have a communication between sub-ICM space and subretinal space. And these chronic detachments lead to RPE atrophy and chorioretinal atrophy. So this is what can be the cause for poor vision, especially if it involves the macula, where the macula itself is just outside the colobomatous margin. Subclinical detachment of coloboma could be identified actually on the OCT. When you see vertical scanning of this margin, we could actually see that this particular section is going between the disc and the colobomatous margin, as you can see, and yet it shows a detachment of the retina. And this is not clinically obvious, and this is what led to this chorioretinal atrophy. And I can't say that it is a rhegmatogenous detachment because there may not be a communication between subretinal space, sub-ICM space, could still be just tractional in nature. I also found subclinical detachment of retina beyond the coloboma that is along this border. When we did, we found this chink of fluid along the colobomatous margin. We also found that if you scan the isthmus between the normal looking disc or dysplastic disc and the colobomatous margin, where the RPE reflex seems to be okay, but when you scan that area, you will find that it's actually atrophic and there's not much of retinal architecture retained in this area between the coloboma and the disc margin. And this, of course, is more severe when the disc is closest to the coloboma, while when the disc is very far away, in between you can have good functional architecture of the retina. The transition from the normal retina to the intercalary membrane can be very abrupt, like in this case. You can see this is the normal architecture of retina, and suddenly it becomes a thin intercalary membrane right at the margin. While in another case, there is a gradual transition where it loses a few outer layers first, and then the inner layers last, becoming fibrotic. A communication between the subretinal space, you can see here the clinical retinal detachment. Between this subretinal space and the sub-ICM space where the intercalary membrane is detached could be demonstrated sometimes by doing OCT serially along the colobomatous margin. As you can see in this section, which is somewhere here, you will find a communication between subretinal space and the sub-ICM space, while the section just beyond does not show this communication. It is sealed now. That means here the locus minoris resistentiae is intact and here it is broken. And this communication is what is needed for the ICM detachment to lead to a retinal detachment. And that is the rationale also in treating along the colobomatous margin with laser photocoagulation. The last study on the OCT was on glaucomatous cupping versus disc coloboma. I found that in a glaucomatous cupping, very often you do find, in a glaucomatous cupping, you don't find any glial tissue in the base of the cupped disc, while in a colobomatous disc very often you will find this kind of a glial tissue. Well, that was just in one or two cases I have found, not that I can consistently reproduce that, nor I have examined or looked for it consistently in the subsequent cases. I also described these form first lesions of coloboma, wherein they don't have typical colobomatous appearance, but they are form first lesions, because I know that the fellow eye, for example, this eye, the fellow eye has a typical coloboma and also a disc coloboma, you can see that. While the fellow eye, this eye, has patches of chorioretinal atrophy almost resembling as if somebody has done some cryotherapy there. And this is like a oral bay which is indented posteriorly. You can see the ora serrata here, but here it just dips backwards. In this spot it's dipping backwards. On top of the dipping backwards, there is also an area of chorioretinal atrophy. Now this is, I would consider as a form first lesion because it's in the same meridian as where you would expect a coloboma, but there is no actual coloboma in that area. And actually OCT of this area showed, the area here showed a near normal architecture of the retina, while OCT of this area showed no architecture of the retina. This is what I was referring to. This is again a small form first lesion. In an eye with an optic pit, which is temporally located rather than located in the inferior nasal quadrant. But the fellow eye has got typical coloboma involving the disc and the entire choroidal area. I mean, most people don't relate optic pit, temporally located pit, with the colobomatous process. But this is one eye which seems to give a compelling reason to think that this could be a part of a colobomatous process, although it is involving a temporal part of the disc and not inferior nasal part of the disc. Retinal detachment, I think I am through. I don't think I'll discuss much, about just one slide only. That retinal detachment, we are looking at three locations: peripheral retinal breaks, a break in the intercalary membrane, and a communication between subretinal and sub-ICM space. All these three have to be looked at before we manage them. The management part is beyond the scope of this presentation. Just to say that by proper understanding and managing these eyes, we have had very good success. Unpublished data, this was the published data of 85 eyes, but the unpublished data, which is updated to 126 eyes of 118 patients over an 8-year period, with a age at presentation of 4 to 46 years and a mean follow-up of roughly 3 years, we found that 94.4% had anatomical success with one or more operations. Sometimes you may have to do a repeat surgery for PVR process. And 56.3% are better than 10/200 vision, which is pretty good vision considering that the coloboma process could involve the disc and the macula. Thank you very much for your attention.